lastly, invite Professor Ivo Mueller to come up and join us. Ivo is an epidemiologist holding a joint appointment at the Institut Pasteur and the Walter and Eliza Hall Institute in Melbourne. His research is focused on three themes: comparative biology of falciparum and vivax host interactions, epidemiology and interventional research in Papua New Guinea and the Americas, and the impact of control programs on malaria burden and host, vector, and parasite interactions. And he's going to speak to us today about targeting Plasmodium vivax for elimination. Ivo.
Thank you very much, Scott, for the lovely introduction. I'd like to also thank the organizers for giving me the opportunity to speak here. It's a real pleasure and a real honor to be part of the symposium. I probably knew Alan less well than most of the previous speakers, but I had a few chances to talk to him about my favorite parasite, which is Plasmodium vivax, and he was clearly very knowledgeable and also understood the challenges, specific challenges, particularly in terms of treatment that these parasites raised. And so I did see in him a kindred spirit in trying to see how we can target that parasite. So the first thing I want to try to convince you of is that it's actually the harder parasite to control and eliminate. And I'm not going to go into much detail, but just to show that when you're looking at all these countries that were mentioned as being in the elimination E2020, almost all of them, the vast majority of them, have predominantly vivax malaria. Those last cases in all these countries with less than 50,000 cases per year, the vast majority is Plasmodium vivax. So that residual tail we're trying to clean up is Plasmodium vivax, and that's cases. When you're looking at prevalence, this is a cohort we've run, two of my students ran in the Solomon Islands, where we followed 1,000 children for a year. And we found almost 900 infections with Plasmodium vivax over a year in those 1,000 children. We found 26 falciparum infections over the entire 1 year. So we had 97% of all the infections were Plasmodium vivax. And that's in a country where they report roughly 40% falciparum clinical cases. When you actually look at what the burden of infection is, it's hugely overwhelming Plasmodium vivax. This is data from LeAnn Robinson, who will, I think, talk more about some of these similar data on Wednesday in her talk, where we had two cohorts in Papua New Guinea where we followed children 5 to 10 for 6 to 9 months and said how quickly they got infected and how much disease they had. And this was before and after introduction of intensification of control. And over a 10-year period between 2003 and 2013, we saw a 10 to 14-fold reduction in risk of falciparum, but we only saw a 3 to 4-fold reduction in risk of vivax. So roughly a third the reduction in vivax, and particularly in the infection endpoints. So why is it that vivax is so harder? That's the key culprit. It's the hypnozoite. So when the sporozoites enters the human body, it can take two paths. It can either develop immediately into blood stage infection, appear about 10 days later in the blood, or it can sit in the liver, dormant, or rather developmentally arrested. It doesn't divide, it doesn't go further until it reactivates months or years later. But that's not the only reasons. Vivax also has lots of low-density asymptomatic infections, more so than falciparum, as I will show, and it's a very efficient transmitter. It produces gametocytes immediately. As soon as you have blood stage infections, you have gametocytes. Whenever you see a blood stage parasite of vivax in a person, there are gametocytes there, always. And so therefore, it can transmit early before symptoms, and at the time when a patient comes to treatment, the person is very efficient in transmitting the disease, which is not the case for many falciparum cases, at least clinical cases. So the hypnozoite. So how important are these things? How much of the disease or how much of the infections do they cause? So we took a cohort of children. That's a study published by LeAnn a couple of years ago, where we took a cohort of children where we removed hypnozoites by drug treatment from half of them and not by the other. And the difference is roughly 80% difference in risk. So children that have hypnozoites have 4 times as many infections as children that do not have hypnozoites. 4 out of 5 blood stage infections in these children were caused by relapses. That's huge. So each mosquito bite causes 1 primary and 4 relapsing infections. So you're not just dealing with 1 emergence from the liver, you're dealing with 5. So really, if we want to eliminate transmission, if we don't start dealing with this hidden reservoir, we're going to be slow, at least. The problem obviously is we have no diagnostic test. We cannot tell whether a person has a parasite in their liver. Impossible. We don't have a test right now. No way to do it. And in terms of treatment, we have 1 single category of drug, the acetaminophen, primaquine, and soon, hopefully, tofenoquine, that are potentially toxic in people with G6P deficiency. And at least primaquine doesn't work in people that have low CYP2D6 metabolism. So a significant part of the population can't be treated with these drugs, or the treatment won't work. Somewhere between maybe 10 and 20%, depending on the population. The other point is in terms of asymptomatic. So how much vivax infections out there are actually asymptomatic? Your average infection of vivax in a population does not cause at least any febrile symptoms. These are 6 different cross-sectional surveys that we've run across the world with very similar methodologies. An order of magnitude difference from 3% to 40% in prevalence by PCR. And basically in all these circumstances, between 80% and 90+% of all infections are not associated with any noticeable symptoms of vivax. So your average infection is an asymptomatic one. Your average infection is also a submicroscopic one. In particularly once you are below 5 to 10% prevalence, the vast majority of your vivax infections are not detectable by microscopy. They are submicroscopic. In some areas, 80 to 90% of infections are below the detection of microscopy. So your average infection out there is asymptomatic and not detectable with any of the diagnostics that are routinely used by malaria control programs. That's why I think the burden of vivax globally is massively underestimated, because the infections are not being detected by the health system in the way how we do look at infections. So how that looks like is an example from Brazil, from Marcos Lacerda and his team, who've done another cohort study where we followed 1,000 people for a year. Sorry, I got to go back. So now I've given away the punchline. But the top is what the malaria control program sees. Brazil has a fantastic passive case detection system, really, really good. They capture almost all clinical cases. That's what they see. There is a cluster of infections up in the top left in that village where there clearly is ongoing active transmission and clinical cases are starting happening. The bottom picture is what the PCR sees in the same period over exactly the same people. So there's a huge cluster of infection in that bottom left that is basically asymptomatic, but is more infections there, asymptomatic ones, than you see clinical infections. That cluster would not be detected even by the best passive case detection system that I know of. So that leaves me to what I call the vivax elimination conundrum. So how do we efficiently eliminate something when these hypnozoites contribute 80 to 90% of all infections? We can't know who has them. The vast majority of infections are asymptomatic submicroscopic and are not detected by the health system. The parasite transmits before we get the person to treatment and can continue transmitting even at low transmission densities. And when the only drug that we have to kill these hypnozoites is potentially toxic and cannot be used or is ineffective in 10 to 20% of the population. Doesn't sound very good. So is the situation really that bleak? Are we really stuffed? And the answer is no. The reality is that we have eliminated vivax from very large parts of the world. If you compare the map on the left that was drawn by Lysenko and Semashko 30, 40 years ago, that it maps the extent of malaria transmission in 1900, and you could compare where vivax is now, the map from 2010, we have eliminated vivax from really large parts of the world. Yes, it's predominantly area with low transmission temperate vivax and not the hard, high endemicity that. But it's really important to remember that every single country that has been certified as malaria-free has had vivax malaria. So every successful elimination campaign has eliminated vivax. And I think it's really important to remember. I've been on record on saying, oh, it's so hard, we need so much to do about vivax, but we've done it over and over again, and I think we need to do that. So what can we do with the current tools? Gary's fantastic talk that he talked about and took all my time up, so I have to talk very fast, is that vector control methods are equally effective for vivax. So when we're looking in PNG, we're seeing, you can see those faint bands that show when the bednet distributions have happened. On the right, when you see clinical episodes, which are largely caused by new infection, by new mosquito bites. They both, falciparum and vivax, drop both in parallel. We have a similar reduction of falciparum and vivax immediately of clinical episodes because they're mostly caused by newly transmitted parasites. But the prevalence only starts dropping quite a bit after the first round of the infection because the liver is still seeded. These hypnozoites keep coming out for months and a couple of years afterwards. So vector control needs to be maintained longer and needs to have a coverage that's longer to be effective. But if you have high coverage of vector control for 3 to 4 to 5 years, you will see the same impact against vivax because you're preventing the formation of hypnozoites. And once the old ones are used up, the vivax starts dropping. What else can we do? So it's hard in vivax. We can't really do large cluster randomized trials because the endemicities are very low and they're really expensive. So together with Michael White in my group, we've tried to use mathematical modeling to see what different kinds of combinations of interventions could do. So we produced a transmission model that we published a couple of years ago and then calibrated that model against various data sets from Papua New Guinea and used that to calibrate it and then fitted it against a number of different systematic reviews. And what we used it then in Papua New Guinea to, on one hand, model the changes associated with intensified control history for over the last 10 years, and then see whether we can predict different future scenarios. This is what it looks like for the 19 provinces in Papua New Guinea, plus the capital, which we didn't model because it's urban. But as you can see for black, it's basically, can we go back?
Yeah, you can go back.
Which one?
That's back.
That's back, okay. So you can see that basically, while in some areas it's really low, we will predict that if we don't do anything, the black line, that it will always come back. The different interventions that we've modeled with 50% LNA coverage, 80% coverage plus primaquine treatment or tofenaquine, and you can see in some areas we really get to elimination, or at least a pre-elimination. But in other areas, it will still keep coming back. So in a bit more detail, this is a kind of a median PNG scenario with a prevalence by microscopy of about 8% and a prevalence of vivax of about 20%. By PCR, that was pre-control. When you give 80% bednet and you scale up the way PNG has scaled up between 2008 and 2014, you see a rapid dramatic drop. If you then maintain bednet coverage at 80% by supplementing bednets every 3 years, you realize that you do reach really quite low prevalence, about 3 or 4%, and you are stuck with Gary's residual transmission. That really means you have only 3 or 4% people that have parasites by microscopy, but 10% or more have hypnozoites. And that's really your reservoir, is that 10%. When we add an anti-hypnozoite drug like tofenaquine to case management, because PNG only does not really use primaquine very well at the moment, then we can drop that quite substantially further, and we reach really pre-elimination level in terms of microscopy prevalence, but we still have around 5% of people with hypnozoites in their blood. So if we add a single round of MDA, then that will further, of MDA with an anti-hypnozoidal, that will further decrease that prevalence and get us really quite close. But in some areas, we probably will require several rounds of MDA before we can get there. So when we're looking at that in terms of PNG, what we will predict of where we could be by 2025, then you can see in the southern and in the highlands part, really bednets will basically get us to a pre-elimination setting just by keeping bednet coverage really high up. Along the north coast, we have to really intensify and improve case management. But in some of the islands areas, we will require MDA to get anywhere near pre-elimination. And in some of the gray areas, we probably actually will definitely require several rounds before we get there. So MDA with ataminoquinolines is in particular with primaquine, is a hard thing to do. But it's been done in the past. China has done it to hundreds of thousands of people. Several Central Asian countries have eliminated malaria more than once using hundreds of thousands of doses of primaquine. Nicaragua, Costa Rica have used MDA with primaquine more recently. But it's really hard to do. You require high coverage. You need DOT, at least for primaquine. You need G6PD testing. So it's logistically very difficult. And MDA in areas when really only 5% of people actually have hypnozoites exposes 95% of people to drugs that are potentially harmful for them, which really then changes the benefit ratio in terms of for the people and also has problems with adherence. So we are really faced when we're doing MDA with vivax what I call a diagnostic dilemma. If we treat only the parasite-positive people, the people that have a positive blood slide or a positive PCR even, then we're going to miss maybe 2/3 of the people that we actually need to treat. And we won't have any impact because everybody just relapses and the effect of the intervention is gone. On the other hand, if we treat the entire population, we are over-treating massively people with drugs, the only current drugs that we have that are not the safest drugs that we have. So maybe there are other ways of going about finding these people. And one of the approaches we have been looking at is the approach of serological biomarkers. Antibodies hang around for a while. And we now have panels on the right of antibodies that give us preliminary panels that give us up to 90% sensitivity and 75% specificity on being able to say whether somebody has had a vivax infection in the previous 12 months. If you've had a vivax blood stage infection, unless you are in North or South Korea, and you've had a blood stage infection, then you are likely going to have hypnozoites. Because all these infections make a primary infections and they relapse within 6 to 9 months at most. So if you can cover 9 to 12 months, then you're going to probably identify almost all people that have hypnozoites. You're going to also cover some that do not have hypnozoites because they no longer have any parasites in the liver. So these biomarkers, we think, could potentially be helping us to both stratify, as was highlighted by Kim, stratify areas into different risks and also then actually use them to target people to basically do a sero test and treat where we go and screen serologically and then test people that are positive with that. Another thing is a bit of a, just quickly before the end, I want to touch of the fact that we might need vaccines. And we've had a lot of talk about the current falciparum vaccines, RTSS, which do not have a great efficacy against falciparum blood stage infection, maybe 50% efficacy. But in order to get 50% efficacy in terms of blood stage, they're probably 95% efficacious against sporozoites. They probably immobilize and kill the vast majority of sporozoites. So again, we've done some modeling with Michael. If you do that for vivax and you knock 95% of sporozoites out, you're knocking 95% of hypnozoites out, which means you're reducing the number of relapses very, very dramatically. So you may still get your first infection, but you're not going to get any relapse, or hardly any, maybe one if you're unlucky. And that will dramatically reduce the chronicity and the duration of parasitemia that person will have. So an RTSS-type vaccine against vivax may actually, as we've modeled on the side, reduce in yellow the hypnozoite prevalence and in red the parasite prevalence, may actually reduce that quite dramatically, quite quickly, because it knocks out all the relapses. So an imperfect vaccine against vivax may actually be more efficacious than an imperfect vaccine, a pre-parasitic vaccine, than against falciparum. So to conclude, I do think the last non-zoonotic parasite, as my friends from Malaysia tend to point out to me, in Asia probably will be a Plasmodium vivax parasite. Elimination is harder, but it is possible, and we've done it. But we do need some additional tools. And if I have 2 more minutes, I quite quickly would make some things to think what we should be doing in terms of targeting it better. Effective vivax elimination needs to include specific approaches to deal with the hypnozoite, so we're not going to get there. There's no way around it. As good as vector control is, that residual transmission is going to keep coming at us. I think there is absolutely no reason why not every single vivax infection detected should be treated with an effective anti-hypnocidal drug, apart from the fact that we have G6P deficiency. So we do need new drugs, urgently new drugs that do not have the same problem. In co-endemic area, and that's a bit controversial, we should probably treat every single Plasmodium infection with an anti-hypnozoidal drug, because the rates of recurrent vivax following falciparum are almost as high as the recurrent vivax following vivax. So the majority of people with a falciparum infection have a vivax hypnozoites in their liver in co-endemic areas. So we should probably treat them all. We have to target also the asymptomatic and the hypnozoid-oriented carriers, so we're not going to really get to the point. Vector control, and that's basically a summary of Gary's talk. Vector control is effective, but we do need to deal with these early outdoor and zoophilic vectors, and Gary told you how to do that, so just go and do that. And we clearly need the novel drugs, novel things, and I do think the 2 most important ones are the first 2, in my opinion. We do need a non-ataminoquinoline anti-hypnozoidal drug that is safer and does not have the issue of G6P deficiency, or this is going to be a hard slog in highly endemic areas like PNG. And having a diagnostic that could identify us and let us target treatment to the people, at least with very high likelihood of hypnozoites, will also help greatly. So lots and lots of people to thank. I'm really a spokesperson for a big group of people that have spent a lot of their time trying to crack the vivax nut. Thank you very much.